So we're going to talk about gender-affirming facial surgery. And what my goal of the presentation is to help participants get a better understanding of anatomy of the face and how it relates to surgery, to understand aspects of facial development that then play an impact in some of the surgical procedures that we do, to using some terminology associated with surgery. So then, hoping that kind of like learning the language a little bit for the individual will come about. We'll talk about the different procedures. And my overall goal for any of the presentations that I give, understanding that very few of the people or, potentially none of the people that are involved in this talk are going to come to me for surgery, but how can I help you interact with the provider that you are going to see potentially in your area to have a more collaborative relationship and to be able to, get your point across. So what I found when I have individuals that come to me that have already had surgery and they're looking to change something about their surgery, it's almost universal that they describe that they didn't feel that they were able to communicate with their surgeon. They didn't feel like this person understood, what they wanted. And I think that aspect of your relationship with your medical provider is, so important. But it's also just, really hard to do that. And you're trying to do it in a small amount of time, and you're doing it in a setting that, few of us feel comfortable in. So to be able to, be empowered to advocate for that relationship that's got better communication is, just at basis a challenge. So what I'd like to do is to help, give some tools in your tool belt so that when you talk with me, which would be wonderful, or, anybody else, that you can, feel like you're an active part of the conversation when you have it. So gender-affirming facial surgery is really a whole set of procedures that can be used by themselves or together to help members of the community that have gender dysphoria meet their goals of transition and to hopefully decrease that dysphoria. Well, so then what is that, right? What are we accomplishing? How do we know if we got there? What do you do when you go in to see a surgeon? So a lot of times I have people that I have a whole, range of people describe what they want, but some of the more common things that I hear are I need to look like a woman. I want to look like a woman, or that I want to be misgendered less. It's, much more kind of rare that someone will come in and, be able to, or kind of out the bat, discuss their features that they'd like to be altered, which is ultimately how I kind of structure my practice, but get there in a little bit. So having an understanding of what we're trying to accomplish is important. And that's, some of the stuff we're going to talk about in this presentation, but keeping in mind as well that, an individual's view is, of paramount importance. We consider this because there's, things that other people are saying. There's, potentially see, physician or surgeon that will tell you what they think that you should change. And there's no right way to be anyone or to look like anyone. And so, really finding, what this, doing exercises, thinking about what this means for you is what I think is really important to getting a surgical result that fits for you as an individual and not, someone else's idea of what a woman should look like. And important to consider that your, ethnic characteristics also, factor in an important way, and mainly, for me and the people that I work with, in a way that is intentional. Because I have, some individuals that say hey, I, know that my mom has a nose that looks like this, and I don't want that. And other people that say yeah, I would like to try to, maintain some of these characteristics as I move forward, but just tweak these other ones in different ways or something like that. And again, it's just for me all about empowerment and choice, to know what you're doing and to not have someone else's view imposed on you in terms of your surgical result. When we look more closely into the comment of, I don't want to be misgendered, of course, I share that with the individuals that I work with for so many reasons, and really hope that this is the case. But it's the most challenging directive to base it off of, because we are thinking about not how we view ourselves, but how someone else is viewing us, and then how they're choosing to respond to it. And you can't, and it's completely out of our control with what that person is going to, how they're going to view us, or how they're going to decide to, talk to us or treat us. And so while, I wish that the world was a very different place in a lot of different ways, this goal for surgery is, external. And I think that it's going to be more helpful. While this would be like a wonderful secondary effect of having surgery, we're not in control of it. So not that we shouldn't try for it, but that we shouldn't, kind of like rest our result, like, in that, and that, trying to be, confident in the goals that we have for ourselves and the way that we, look ourselves is going to lead to longer lasting satisfaction. And that's kind of what, we have here, is that we can do things, have specific procedures to treat dysphoria and fulfill your embodiment goals. And then hopefully, create a sense of pride in your appearance would be, what makes me so happy when I hear and talk to people that have had surgery and they get there. And it's, people definitely do. So part of the challenge of talking about gender affirming surgery is in, doing so in a way that is as sensitive as possible. And my own, evolution of language has, certainly been just that over time. I usually at the beginning of the talk, give a little caveat to say like, hey, if there's something that I say that doesn't resonate with you, in whatever way we can talk about it, I would love to hear it, because I'm, learning every day on how I talk, how it could be improved, and how I can, try to just do better for like everyone as a whole. It's a challenge because, different people, use different like, terminology, and it doesn't make it, right or wrong per se. And that's kind of what's in this first point that I'm referencing, that I've been as a change of my practice when I'm talking about facial surgery, to try to avoid terms like facial feminization or facial masculinizations. Now, to some point, they're super helpful because they're the way that the community, describes the surgery procedures themselves. And like, fuck me for being some cis guy to tell you what we should and shouldn't say. But I want to be sure that I'm capturing people too, that maybe like being feminine or masculine is not necessarily the goal. And I don't want people to feel alienated that, that think they want facial surgery, but they don't want to be like feminized. So like, where does that leave them? So I really try with, basically all the procedures that I offer to try to take out those terms like masculine and feminine and describe the procedures in terms of their result that they can offer. And then, allow an individual to see kind of like which most fits their goals. And facial surgery becomes such a complex conversation because here's a list of procedures that I put together that is probably not even like all inclusive. So there's so many things that you can talk about. And this is one of the reasons why, I like to give these talks, and I give that goal that I did in the beginning, that I would like you to be able to show up to a provider and be able to have a conversation about your surgery. And it's like, it's not like you're talking about like one surgery, like one, facial surgery could be made up of like 9 different procedures. Each one of those procedures has factors that are important to surgery, like the risks and benefits, the incision, how it's going to be done, the expected result. And it just makes these conversations like so challenging to have, and why we need to, have more talks about it, but also find ways to kind of simplify it in a way that, people that are not surgeons can understand and can be able to communicate about. So for that reason, when I talk about facial surgery, I think that it's convenient to break it up, or makes it easier to break it up into 3 different parts. And we have upper face, middle of face, and the lower face. And that's why, because of where I drew these boxes when I made this talk, that's why we're not talking about your cheeks. I'm sorry, I just do what the boxes say. So anyway, so we're going to start with the top, and then in other talks, I will, move progressively down the face. We're going to focus on the upper face. So here's a video that we developed that helps to show what happens to a skull when it is exposed to testosterone during puberty. And I will start this while I talk, but in the upper face where we're talking today, you'll see that you get this kind of like gull wing shaped prominence that happens right above the eyes. The shape of the eye as well becomes more square, and we have some more prominences kind of like right above the eye, so that this whole area is more heavy, has some fullness. Immediately kind of like up beyond that, there's a little bit of a dip, and then it goes to your like rounded forehead. So primarily what is happening here is that there's a sinus. Like, people think about their sinuses like in their cheeks. There's like one up here in your forehead too, called your frontal sinus, and that expands and enlarges. And once that has enlarged, it is not possible that like hormone administration, taking, estrogen, will reverse the bony changes that occur. So, hormones do really good at like soft tissue changes, but they're much more challenging, when we come to changes that have been made in the bone. And I've, not known through any, research or conversations with other providers to know someone that's been able to change their bone structure through hormone use. You can prevent your bones from making this shape, like if someone is an adolescent and goes on pubertal blockers, but once it's happened, it's not something that we're going to be able to change. So that's why we have surgery. And it's important to consider that, not everyone is the same. I showed, what happens in some people's like skulls with the frontal sinus development, but there's certainly, race-based changes that we see in this area, and the way that a person kind of grows up, what we call their like hormone milieu, will have a role on kind of like how these features develop. So here's some examples they're taken from a CT scan that kind of show this in like a real life skull, not an animation. And you can see, let me change to my pointer here. I love the pointer. Okay. So here's this here. This is the frontal sinus. Like I said, it's kind of a gull wing shaped thing. These holes here where nerves come out, which is like kind of cool. And then if you look at from the side, you see a little bit or you see this more prominence here, and then it goes down to the nose. So you have this kind of like sharper angle there. You also see that the eyes themselves, like the shape is more square, and then that there's this like prominence right above the eyes. So then this is a picture of that skull from the side, and we have the frontal sinus here and then the nose, and it makes this what's called the nasofrontal angle. And in this person's skull that has the appearance of someone that was exposed to testosterone, it has more of an acute angle compared to someone that has kind of a more flattened area here. Then with their nose, it makes more of a obtuse angle. Okay, I have to go do something real quick. I am going to mute, but then I will just be right back. All right, back. Sorry about that. I don't know if anyone could hear, but my dog was just like going like nuts. So we have this prominence here in the region of the frontal sinus on the skull, and this is what we're really going to be addressing in the upper face to make the changes that we need, or that someone might want. Wow. Okay, there we go. Cool. So when we talk about, like I said, like I'm trying to avoid terms like masculinization and feminization. So then, how do we talk about what we're going to do? And so how I kind of like to organize these is in what they're going to accomplish. So here's a list of procedures that will provide a softening of features, a reduction, make something smaller, or we decrease the angulation there. And those include the brow reduction, like we just were kind of discussing. But along with this, because of the way you do a brow reduction, there's also opportunities for hairline changes and a brow lift. And then separately, there's things you can do in the soft tissues, like with your eyelids and your temples, which we'll discuss briefly. When we talk about building up procedures or augmenting them, making them bigger, we can do that in this brow as well. And we can mimic this kind of shape here that is more prominent in those that were exposed to testosterone. And accompanying this, we can also make changes, since we're kind of addressing the upper face, in the hairline as well. For non-binary individuals, it's important to consider that, and I mean, this is true for everyone, not only for non-binary, but you can, pick the procedures that fit with the way that you would like to change your appearance to hopefully, to decrease dysphoria. So no one needs to be, locked in to one certain route, because we need to be treating the individual and, what you would like to change by yourself. So in general, when we're looking at facial surgery, and kind of with any surgery, what we should ask ourselves with each individual procedure is, like, how are we going to do it? What is the incision point, going to be? What are the risks and benefits? And what is my result for me? To what extent do I want this done? Do I want like a super aggressive result? Do I want something that's like more subtle? Upper face procedures as a general class typically are can be like a big payoff for people when you're like addressing kind of like the eyes and the forehead. We saw this like when we were like being like masked a lot, that changes up here really change someone's, gender expression, like very strongly. And the good thing about that is that, because it's kind of the top of your face and with gravity, it's hard for swelling to stay up there. You don't have a lot of swelling compared to other areas like your jaw, where you might stay swollen for like 6 or 9 months. So the results are, more immediate after. And then it's important though, because with any procedure on the face, planning an incision, it could be in a visible location. So it's not, something to take lightly. I have kind of a fun story, years and years ago when I was back at Kaiser, I did a procedure, I did a frontal sinus reduction on someone, and it just happened that, this individual got like very like bruised black and blue eyes, which doesn't always happen to people. Sometimes it happens in like one or the other, but to some extent. And I go in to go like see her in the hospital like the next morning, and she's like, "Doctor, like I look like I got hit by a bus." And I was like, "Oh gosh, like sorry, it's normal." And she's like, "No, but I look like a lady that got hit by a bus." And so but it's kind of a cute story because she was like so happy, but she definitely, wasn't like not obvious that she had had a procedure done. So when we take a look at these upper face procedures, as we mentioned, we're going to take a look at hairline advancement, brow lifting, and the brow reduction. This individual here kind of helps to display what we're looking at just with half of the face, but we see that there is a rounded hairline here. We have the brows in an elevated position. There's a little bit of an arch to them. And then if we were to look from the side, we would see that there's not a lot of prominence here, that the forehead in profile is more convex. And then we have this kind of like open eye without like a lot of prominence here off to the side. The overall face shape, as you see on this half, is more like rounded. All right, back to these images from before. So we have already said like this is our frontal sinus. This is what we want to take down. Well, this is what it looks like from the side on the CT scan. And black is air on a CT scan. So this is the air-filled cavity, and this is that thin bone that's in the front of it. And this is the reason why we have a procedure called frontal sinus setback, because we have to remove this to make this be, overall kind of like more rounded. We'd have to take this bone off and then, put it back in a recessed or, setback location so that it would, be kind of round and not have this shape. You can see it in this. This is very thin. There's no way that I could use like a kind of medical, sander or a burr to flatten this out without entering into the sinus. And, because the sinus communicates with your nose, you can't just have like an open sinus in your face. Here's some more CT scans, the 3D reconstructions to show what we take a look at. This is the nasofrontal angle here that we try to go from being acute to obtuse, try to remove this prominence here. And then another thing you can do is to kind of use some like contouring material to fill this gap so that you don't have a divot here. And that is something that I feel helps with, achieving that more like convex shape of the forehead that people are after. I don't think there's much else. There's, as we see the prominence here on the eyes, and we see that the shape of the eye is, a little bit more of a square. These ones could be a little bit, they're pretty circular already. Okay, so again, and this is a close-up of that person's CT scan to show that if we were to want this to be this kind of curvature that I'm showing with the pointer is not possible with how thin this bone is. So we'd have to do the setback. Here's an animation of that. It's, simplified, but you cut that bone off and take it off, do some contouring, smooth things out, and then you put it back in a more flattened position. And then you get this kind of more rounded shape to the hairline. The hair would be here-ish, so you wouldn't necessarily, see this little bump here. But that's something that in my results, if I can avoid it, I try to just make this whole thing round. So sometimes people come in and they have, done their research and they're like, I know that I want a type 3. So then you're like, well, what is that? I try to avoid using these types of terminology because could be confusing if you don't know, and it's better just to be descriptive. So if you're a type 3 corresponds to a frontal sinus setback, but there's also something called a type 1, which is where you don't have to do the setback. The bone actually is thick enough that it could be contoured to made more flat. So if you look at this, and I got this from a research paper that's cited down here, they show how thick the bone is. And then you could see that like, if you were to like smooth that down, you could make this a rounded shape and you wouldn't actually have to remove someone's sinus like you would in this person here. So type 1, type 3 comes from a surgeon named Dr. Osterhout, who invented it. People still use this terminology to avoid confusion. I don't, because I don't want people to have to memorize like one or the other. If, your anatomy has this thin walled sinus and it's, more prominent than what you would like if you could make that bone thinner, then you are going to be relegated to the setback in order to achieve the results that you're looking at. Sometimes with people, when I have a conversation about the risks and benefits of the surgery and they have like a relatively thick bone, they decide that since maybe this isn't an area that's causing like a lot of dysphoria, it's just kind of like, not the top priority, then they say, well, like, do as much as you can, and then I'll avoid myself from having this like sinus surgery that could have more potential complications down the road, because everything comes with complications. So this is kind of what fits into that category, like I was saying, of making sure that the results and what we're looking to do all kind of match up with what's important to you. Because if you, go in to see someone and they're like, okay, we're going to do this, and they're going to, make this change for you, you don't want to be exposed to more risks or the need for more care down the road, potentially for something that's not a priority for you. So when we talk about this brow reduction, how are we going to do the surgery? Well, we're either going to do the setback, which is like what I showed, or we're going to use contouring. This is an important point here that we're going to discuss for the next few minutes, is what will be the entry point? So what incision are we using on the face to get access to your brow bone here? And that's what's called a coronal incision. So coronal, kind of like from the Latin word for crown, comes up and over the head just like this. And we can do two different things. We can put it in the front of the hairline where we can make changes to your hairline, but it's visible, or we can put it back a few centimeters where you're not going to see it, but then we can't make changes to the hairline. And I have some pictures that are going to help to show kind of what we're doing there. With all surgeries, some of the risks, this is going to be true for everything, but I just didn't mention it after this, but bleeding and infection are always risks for surgery. And then particularly because if we take off a piece of bone and then put it back, that bone could not heal, which is called a non-union, or not heal, right, which is called malunion. A mucocele is where like the mucus of your sinus gets like stuck and trapped in there. And then you ultimately might need a surgery to like, drain that or release it. Mucocele comes up like, 3 to 5 years after you've had this procedure. So unfortunately, you can be like trucking along great and then have that come up as a problem. And of course, like all surgery, having the desire for something to look differently, more reduction, less reduction, something like an asymmetry to be fixed is a risk as well. So one of the things that's kind of fun about doing this procedure, and with modern medicine that is through in here, because some of your surgeons might talk about this and use it, is that you can now use 3D printed cutting guides that can help the predictability of your surgery, and the surgeon can decide like what they want to do prior, so you're not like figuring it out like during the surgery. I would say most people probably do not use this and they have other methods, but just to know that it's something that is out there. And here's some work that I did for someone, a while back, when we take their CT scan, take a look at like what part of the sinus that we want to cut to get it off. And then this fits perfectly to their forehead. Sometimes like I actually use these marks here to show me like how much of the eye I want to open up so that it's like more round. This person didn't really, need it. So it's not like, demonstrated there, but I get all this other fun information, like a heat map of how thick the bone is, and then other ways to show me kind of like, how much setback that I want to get, or how much is possible based on like the thickness of the like surrounding bone. So this is something, fun to do. So the brow reduction incision decision, like we talked about, you can either combine it with hairline advancement and have a visible scar, or have a hidden scar, and we can't change your hairline through, surgery alone. So here's an image that, to leave my pointer, this will show us, or this video will show us kind of like what happens in hairline contouring. So we said that, like, for lack of a better word, for someone that has a more feminine appearing upper face, has a rounded hairline, the opposite, someone that has had more exposure to testosterone early on and over time, has this kind of like M-shaped hairline with like a recession back at temple. So we see how this one starts, that has more of that M shape, and then, with time it becomes, more rounded. So we can do that with hairline advancement, But the thing is, the scar has to go in the front of the hairline. So we see some real life examples here. Sorry, I didn't verbally announce that. Trigger warning for patient examples. We have someone who had surgery in another country. They had their coronal incision back here where you can see it. And then they chose to do hair transplant to, try to like bring their hairline down and reshape it and then to cover up their scar. It came in to me because they wanted to have, more of a result than what they had after the first surgery. I hated doing this because like this was not cheap, but like I didn't think that these hair transplant looked very good. So I actually just took them out and then did like more of a hairline advancement to, sorry, let me get my pointer on because I'm like pointing at stuff, so I had, still had a little bit of recession back here in that kind of like M shape. So I aimed to, bring it forward and make it more round and then just get rid of this kind of like sparse hair that was like there in the front. And then at the same time they hadn't done like a setback. They had done the like type 1. And so I just converted it to a type 3 and helped for it to become more round. We see here's the incision here. And then at the same time that it pulls your scalp forward, it also pulls your brows up. So she got a little bit of a brow lift there as well. Here's another individual that I worked with. And again, demonstrating like this is that kind of like M shape recession that we're talking about. And many of the people that I, work with when we talk about like, what are your goals for your hairline? It's, have it be more rounded rather than just having the whole thing just like brought forward like as is. And then the people that I, again, see that have had surgery elsewhere that are looking to change things, if they're unhappy with their hairline, it's often that they didn't kind of like know this was like an option or something that you could do. And then the surgeon just brought like everything down. So they had a shorter forehead, but it was still with like this shape. And they wanted something to be changed about it. Also can see that we took her forehead down a little bit to make this more of a obtuse angle layer. So here's a demonstration. So we did say it's visible to know like how it heals. So we have how the scar looks at 1 week versus how the scar looked at 6 weeks and then like, 3 months. So it does typically heal quite well. We can't say that that's true for everybody, and how scar is important to consider with this because it is going to be in a spot that's openly visible. Another individual that I worked with a separate time, this is like 6 months, like down the road. So typically heals quite well. But if you are a person of color, might have known risk for more hypertrophic or keloid scarring, it's very important to consider what could possibly happen because it's going to be right at the front of your hair, where people are going to be able to see. So for hairline advancement, how are we going to do this surgery? We can either, do it through changing or like cutting out the skin where you would like to, have more hair and bringing everything forward, or you could potentially forego having, that visible incision and do hair transplant. And you could take, hair from, the back or a place that, might have going, and then bringing it up to the front and making it more round. So I showed that example of someone who didn't necessarily have like a fantastically performed hair transplant, but that's not the way that it, goes. A lot of people do a really excellent job and they can just disguise how it looks and not make it look, like how that did. So you could do hair transplant to achieve this as well. And that's an important kind of like modern consideration that if you don't want to have a visible scar, that's an alternative that works really well. Hair transplant, I haven't known to be, I don't offer it in my office, so I can't speak entirely to this. I haven't ever known it to be covered by insurance. It can be expensive to have done. So when we talk about what's the incision going to be, it's either that coronal visible incision, or not an incision with like the hair transplant. Risks are that visible scar and how it heals are kind of like the primary concerns there. So next, when we talk about what we're going to achieve, as I said, that the same way your hairline comes forward, your brows can come up. That's called a brow lift. And there we go. So we are going to show what a brow lift does. This is a funny video that I kept and I still use because I think it demonstrates the point, but it's really funny that the eyebrows become like very thin in the course of their becoming like more like feminine in presentation. And so if for more kind of like a true to life example, they could have like, started out like not as thick or ended like the same way. So like a brow lift is not going to, thin your brows. Shaping your brows can do, great things like further shape. But what we're trying to do in a brow lift is to raise them up and to give them a little bit like more of an arch. How do we do that? Well, we can do it with taking out skin. That's again called a coronal brow lift. Or there are these implantable devices called endotines, which are dissolvable over the course of about 6 months usually. And they actually go in the bone, and they have these kind of like little like rakes that your skin sit on, and they kind of like hold the skin in place as it heals. So you get a more, in my experience, long-lasting result from your brow lift. These typically can make people have a little bit more like discomfort, like headaches on the first 3 months, like after they're placed, and they hurt if you were, or they hurt and they're like visible if you like touch them. They don't necessarily like hurt like all the time, but I was just thinking of how like almost I feel like everyone that I talk to and they come back, like let's say we come do like a different procedure and they had these in that like they were in contact with a toddler who like threw a shoe and like hit them in the face, and it seems to be like a near universal experience, like where the shoe hit them in the face is like right where this like brow lift endotine was, and they were like, yeah, it hurt so bad it like stomped me. So really like exposure to toddlers is a significant risk after having like a brow lift. I'd recommend to like avoid it for 3 to 6 months because they seem to like do this thing with their shoe that isn't, I've heard it from like 6 different people. Okay, so we talked about the, did I go back the wrong way? No. So the brow lifts, how can you do it? You can do it with the skin removal, which will help to bring things up, or you can, or you can use those endotines. And so you can actually do a brow lift without these visible incisions, with incisions that go like back in the hairline, and the surgeon can use like a camera to go and like, lift things up and then pull them back that way. So you don't have to have a visible scar with a brow lift. We do it at the same time of hairline advancement and a brow reduction because it's kind of like all done at the same time, but you don't have to. And then what are some of the risks? So you could have, end asymmetric with one brow in kind of a different spot, or, maybe not the result that you want. I typically, or not typically, but I counsel people that I personally overlift someone's brows because they will, settle over time as things relax. And so if you end the surgery in a spot where you're like, hey, that looks good, in like 3 months, it's kind of like gone back to where it was. So I think it's, you tell people like, hey, be cautious. You're going to look a little like overdone at first. If that's good ultimately, because then in like 3 to 6 months, they'll settle down to a spot that's like, acceptable and is not been like too low. Some other procedures in the face. So sometimes people ask, or the upper face, to fill their temples. So we talked about how the face shape is more round in people that haven't had exposure to testosterone when they were younger. And so filling in some fat here can do that. And then you can also do procedures to change like the shape and the angle of your eyes. Those are called canthoplasties. And then there's also procedures with your eyelids as well if you have excess skin. And that's kind of a combination for like a rejuvenative procedure, something that happens to us as we age to have more skin. Although, certainly I've talked with, people that are like, heavily have dysphoria from having this, like excess skin of their eyelids. If you're thinking about having an eye lift and you haven't had a brow lift, my strong recommendation is to the brow lift first, because a lot of times like pulling up the brows will actually take up this extra eyelid skin. And a lot of people, like after having a brow lift, don't end up needing or wanting to have the eyelid lift. But if you do, take away your eyelid skin and then later go back and do the brow lift, then you might not have enough eyelid skin. It might limit how much you can like raise your brows because you've already taken your eyelid skin out and you want your eyes to close or else they get dry. So I think, so the first step is to do a brow lift. You can do a brow lift and a eye lift at the same time. I don't like to do that because it limits kind of like how much you can do with either one of the procedures, because you've got like competing goals, the brow coming up, the eyelid coming down, but it is a possibility. So when we talk about augmenting the face or making things potentially more angular in the upper face, we were demonstrating, get my pointer, that we have that M-shaped hairline here. The brows are kind of like low and flat and straight. And then there's like more prominence here in the middle of the face. So we could build up some prominence here. We could try to find a way for the brows to come down. We could change shape to the hairline that would make the changes to if someone wanted to have more of this appearance. Augmentation for the brows, we would do it through incisions, kind of similar to what we talked about for brow reduction. Like up here could be hidden because you're not typically looking to bring like the hairline down. In this case, we don't usually do it with a hairline advancement. Not to say that isn't possible. It would be, convenient if somebody wanted to have that, because you'd be able to use that same incision, but you don't have to. Typically use an implanted material like silicone, not free silicone, but like a silicone, implant that's pretty stiff because you're trying to recreate bone, or methyl methacrylate, which is another material that we can like sculpt with in surgery. Some of the risks of this would be like the implant not being in the right spot, which is malposition. being asymmetric, having a fluid collection, which is called a seroma, or just like not liking kind of like the result is like where it's at. Here's some images of brow augmentation with this was a silicone implant that was made to make more brow prominence here. And then this is what methyl methacrylate uses. So the surgeon kind of like molds this like during the surgery to make kind of like more brow there. This view, this would be like the hair here, and then these would be the eyes. This is what a coronal incision does that goes up and over your head. So then this is going to be graphic, can flap the skin down so you get a view of the, the forehead and then the brows here. So like we said, we can use silicone, we can use methyl methacrylate. We don't typically use, like a lot of places we do fat injections to build volume, but since we're recreating bone, you really want to use something that's like more rigid, like either one of like these two materials here. If you wanted to make changes to your hairline in, kind of in any way, so you can do hair transplant, you could like, when we talked about filling in like this area here, like let's say you wanted to have more of a widow's peak, you could ask the person to shape that for you. You could combine electrolysis, so like taking out the hair in these corners to make it more square, then with, adding some hair in the front if you wanted to have a more M-shaped hairline. It's hard to shape the hairline by cutting it out in these types of procedures. Like if you're trying to make the M-shaped hairline, because it's going to raise the brows, and that's oftentimes like in the opposite direction of where people want their brows to go. So instead of there being like a surgical option for hairline reshaping to have a more like angular hairline, you usually have to resort to like one of these two procedures here or both of them. And then for the brows, like if someone's got arched brows and they don't like that, you could potentially like remove some of the skin below them to bring them down, and then you'd have a scar like right below your eyebrow. Or you could use chemo denervation, which is like Botox, which would paralyze the muscles here and then bring the brows down that way. So a couple different options for that. If you were going to be, doing something that involved an incision, just keeping in mind that like they're an invisible place on the face. So when I thought Zora was going to be part of us here, I had her included in our like thanks, like, with our families. But I want to leave plenty of time for questions. And thank you everyone for listening to my talk. Sorry, I had to step out for a moment. I'm glad that this is going to be recorded in perpetuity for that. And I'll be excited to give it back over to Rai and do questions.
So thank you so much, Dr. Facque, for all of your amazing knowledge, as always, your wisdom, and also just like the stories from your patients and their experiences is so great and also kind of funny to hear. I'm still thinking about the one where she was like, "Oh, I look like I got hit by a bus," but like a woman who got hit by a bus.
Yeah, I know. I thought she was,
amazing.
I thought she was like mad at me, like the way that she said it first, and then she was like, "Nope." It was super cute. I loved it.
No, that's great. We have a bit of time for some questions, so I can kind of go at from the top of the list down. Dr. Facque, would you mind
Oh yeah, want me to
undoing? Oh, here we go.
get
We
rid
can
of
do
this?
that. There we go. Okay. So the first person, or one of our first questions in the box, said this person said that they're on HRT for slightly over a year but had to stop due to some side effects. Where 7 years has passed, are they still eligible for FFS after all these years? They were told that they need to be on HRT for at least 6 months.
Yeah, so in my practice, for exactly that reason, I don't have any requirement for someone to be on HRT prior to surgery because it's not representative of many people's, transition or care journey or where they're at. I think that facial surgery is actually a great use, or in that way, especially you think about there's some like non-binary individuals that like went on hormones, didn't like some of the results, liked some of them, but went off for that reason. So using surgery to kind of like get specifically like what you liked about it without having some of the other side effects is a great use. I have not had, in my experience, anyone not able to have surgery through insurance purposes for that reason, because because I don't think it's like a modern understanding of gender affirming care. So my answer to that question is that, you would absolutely be able to have surgery. Things could be like provider dependent, because there's definitely different views between providers of like, kind of like what they want. And, I would try to, in a very like polite way, because you don't want to make somebody defensive, but to ask them like, what the rationale is, like what they're hoping to get out of having you on HRT, and see if that seems like reasonable to you.
For sure. Thank you. The next question is, can reducing the forehead/brow impact the function of the frontal sinus? They are a scuba instructor, so they're wondering how that could potentially impact the frontal sinus's ability to equalize pressure during a dive.
Yeah, good question. There's not, any kind of like medical studies that I can use to help answer this question for you. It, is important to consider that you are going to have a disturbance of your frontal sinus. When we put the bone back, it will then heal like it's a broken bone. So you will get a bone in your sinus in continuity. And so I wouldn't expect that you would, you should have a healed sinus when we're done. You also have the two ducts that go from your frontal sinus down into your nose. And those, if the surgery is, not done in a way it should be, because you wouldn't do it other ways. But if there's not an unexpected side effect, those should be open as well. So you should be able to equalize pressure from that. When I described a mucocele, that actually occurs from having blocked nasofrontal ducts there. So it is a possibility that that could happen, but it would be an unexpected side effect. So that being said, if like my livelihood relied on my sinuses like being intact, I would, have that conversation with, physician surgeon to look at my particular anatomy. Like we talked about, like maybe then you're a really good candidate to have it just be kind of like contoured as much as possible, because you're like, hey, if this doesn't work, like I'm out of a job and that's just too much to lose. But it gets to be a personal decision for you with exploring like the risks and benefits with someone that can kind of help to predict like, what your outcome could be.
Awesome. Thank you so much for such a thorough answer. That was amazing. And this other person says, how would you go about finding a recommended plastic surgeon who specializes in FFS, among other things? It's not state specific, so I guess more of a broad question.
Yeah, good question. So the WPATH organization has a list of providers on it, and that would be a great place to start because those are people that have been vetted by that organization as providing gender-affirming care. So that would be a good place to start. They do have it listed by state. That can help you to kind of like see like what would be like nearby. And then otherwise, like I would hop on your search engine of choice and put in these like keywords, potentially the procedures that you're looking to undergo, and then see who comes up. And, look at the website, shop around, look at like before and after photos, and then, decide who you might want to talk to and kind of go from there.
Great, thank you. This person asked, does Fosamax interfere with sculpting the bones, the brow ridge?
Not to my knowledge, no.
Another one asked, if they were to send you a picture, could you tell them what they need done?
I don't do that. And people get mad at me for that because they're like, tell me. And I like go through different like exercises and activities with the individuals that I work with to help to figure out what's contributing to dysphoria. Because I really just in no way want to be that plastic surgeon that you like walk in and I mark you up and I'm like, we're going to do this and this and this. Like, yeah, I have a lot of opinions on, the way that kind of like people look, but like it doesn't matter because it's like not going to be my face at the end of it. So really work on, getting each person to help figure it out for themselves. But as I said at the start of the talk, like that's really hard because people are like, I'm not a surgeon. I don't know. How am I supposed to? And so then you can tell I've had like real like combative talks about that I'm like, that's cool. You don't
A lot
have
from
to.
experience.
Yeah. That like you don't have to know. I do know. So like let's have a conversation about like what you could see being beneficial as being different. And I'll tell you kind of what matches up with that. Using photo editing apps is really helpful. I have people sometimes show me like pictures, like if they've ever edited a photo, be like, well, what do you do when you edit your photo? And they're like, oh, well, I change my cheeks or I like do this with my eyes. And I'm like, okay, cool. Like that's a brow lift, And so there are ways to get around it. No, if you have a conversation with me, I like will not tell you like what I think should be done.
And that's great. It's very I'm sure it can be a little frustrating for the recipient, but it's also like you're kind of removing your own opinion as much as you can in the process to like help them find their own
like who
self.
knows, like maybe someone like loves their nose and they're happy with it and it doesn't stand up to our like bullshit aesthetic appeal standards that we have in plastic surgery, and I'm, instead of celebrating something that's not causing dysphoria when like everything else is, I've now given them something else to think that they need to be changed, and like I just would like never ever want to do that. So
yeah, and that's really beautiful, just trying to give folks the autonomy around all of that. And you also just you brought up something related to the next question. Do you know of any apps that show possible outcomes of what you might want? You talked about photo editing apps.
I've been involved in a couple studies that were aiming to develop this, and I don't think I don't know any that have like come out that have really been great to use. Like there's some that like predicted changes, use software that I just kind of like mentioned to say like, okay, well, if you make this change, like what could happen is like a soft tissue change. And I just haven't, if there was something that really helped with this, like we would use it and I don't know about it. So it's not to say that it's not out there, but I don't know about it, and something that can like specifically do like surgeries. I've seen people kind of like bring in like printouts of different stuff that might be on like select people's like websites. And so to this person's point, like the hard thing about doing like Facetune is that like the changes that you're making are not like what happens in like a surgical procedure or what you're doing with like, Photoshop. Like it's not necessarily that, but your person that you're working with, like, could help you to understand, to be like, if you've made a photo that you've edited and you were like, I want this, they might say like, okay, well, I can do like 50% of that. Or like there's ways it can just like spark a conversation. It's a good question. I should go do like another like research into that to see if someone's like got that yet.
For sure. Also have a sort of recommendation. This is more specific for those who are trans femme. There's this person on YouTube. Her name is Victoria Rose. We've actually collaborated with her. She does these videos around feminizing makeup, and she actually uses techniques from understanding how surgeons do their facial surgeries to kind of inform how she does her makeup, essentially. Super interesting. It's not something I've ever really heard before until I met her. And so I think that, and makeup is also very genderless too. This one is specifically around feminizing. Actually, another person, sorry, I'm just going to give all these different recommendations. I love these people. There's this other person named Jay. Their handle is called Tiebrows. They've done a masculinizing makeup event for us. So in the same way, makeup can be used to feminize or masculinize your face. And I feel like there could be a way of doing that. If you do that enough and you're kind of understanding what makes you feel good and what makes you not feel good, then that can be the thing that informs how you approach your facial surgery consultation. I don't know, just the thought that I had.
No, it's true. And it's another way to think about like, yeah, when you do your contouring, if you do that, like, what do? Do you like draw your eyebrows higher, draw your nose more narrow? Like when I was first starting this, when I was a resident, actually, is when I was like starting to appreciate drag more. And that was at a time that like, Drag Race was like gaining popularity. And I was like looking at like what they were doing with their makeup and learning about contouring. And I was like, oh my gosh, like this is so informative to me as like a provider that's looking to replicate these changes in people. Because you have, some people's like very strong, features that then all of a sudden, like an hour later, they look dramatically different. And it's like, well, how do you accomplish that? So yeah, makeup is super cool.
It's like it's a science and an art and everything.
Seriously.
So cool. Next question. Can you talk about canthopexis and canthoplasty work and the results that they can achieve?
Yeah, I don't do these. I don't like these a lot. People come to me for them. I'm like, you should find someone that's like really dedicated to like eye surgery to do these, because I find that like I don't personally think that like the results from them like look a way that I would like to provide someone with. So like, and that's another thing about just like going to like providers. Like some people have, things that they like know that they like do well, and like hopefully they'll admit to you and something is like not their forte. So when people come to me for this, I'm like, that's cool. Love for you to like have this conversation, but like this is a good idea to talk to Dr. Lee because she does a lot more than I do. So I was actually hoping she'd be here specifically for that reason, because I do them and I know that she does, and it is like a missing talk about this. So to this person, I'm super sorry. It's not that I like can't describe like what can happen, but like as much as the detail that I really go into this is they change the like angle that your eye is at by moving the corner of your eye. You could move it like up or down. So sometimes people want to have like more of a slant, so you can kind of like pull it up. The difference between canthopexy and plasty is really like just the surgical technique of like how you're moving it and how you're like securing. So because that procedure exists in the realm of like cis cosmetic surgery, and trans cosmetic surgery too, you could go to as a resource the American Society of Plastic Surgeons, and they're going to have like some, in addition to like people's like general like websites and stuff to talk about it, but they're a very reputable source to talk about like what this procedure accomplishes and like what the risks are. And pretty much for like, I think for any procedure, they have like provider submitted before and afters that you can like view on that. So it's asps.org, but it's American Society of Plastic Surgeons.
And I'll send that website link
Yeah, thank you.
to the chats. Thank you. I kind of just converted to plasticsurgery.org when I typed that in.
Oh,
So
there you go. Perfect. I don't even know what the website is.
for sure. Someone had asked about full face motorcycle helmets. What is a reasonable time expectation before swelling goes down sufficiently to safely or comfortably wear a helmet during post surgery?
I am so mad. I'm going to dinner with Zara tomorrow night, and I'm going to yell at her for the first 15 minutes because she is like an avid motorcycle rider. She talks about herself like on these presentations. I'm not like outing her, but like she's had facial feminization surgery. So I would be like, Zara can answer this. In general, the swelling, like significant swelling, comes down in the scope of like 3 weeks to maybe like a month. Now we're talking about like in the jaw. When we talk about this like later, you can get significantly more swelling there, which is kind of presumably like what you're referring to. And I do tell people that it takes upwards of like a year to totally see a result from jaw surgery. But that is to say that like most of the swelling has gone down, in the first couple of months after that. So I wouldn't anticipate that motorcycle helmet would not fit for too long, but if you had surgery, you'd also just be able to kind of like tell with, how much like room was there.
For sure. We only have a few questions left. This one is, what are the weight/BMI restrictions that must be considered for facial surgery?
Yeah. Weight BMI just on its own is not a marker that I use exclusively to determine someone's like surgical candidacy. It needs to be like an overall picture of their total health. So it's not going to be, in my practice, a cutoff, a reason that we can't do the procedure. That being said, when we're talking about, again, that risk benefit discussion and we're looking like what's going to be beneficial, you and the surgeon should talk about like, what is kind of going to like, get you what you want. So like forehead stuff, like it's like you probably have like some fat in your forehead, but it's not like the rest of, our bodies where fat accumulates like more readily. So like I'll happily do, I mean, I have to do any procedure for people, but like, I'll do this in the upper face and know that like the weight's not really going to factor into that. Whereas like if we're talking about like chin and jaw changes where people do carry like more weight, the bone portion of someone's jaw could be like relatively low if they are at a higher like weight or BMI compared to like their overall tissue thickness. Typically, I, have the conversation, well, like if we can make it more narrow with the bone, like, anything can help sort of thing. So I'm not going to, even in that case, tell someone I wouldn't do it. But what I try to counsel them is that their result might not be, super noticeable because they have, like more soft tissue that's kind of like making that like shape on their face. And so then we just get to get into someone's, kind of like risk benefit discussion, like what makes sense for them. So no cutoffs for me, but you have to take a look at the whole person's like medical history.
Got it. Thank you. Are there any considerations when someone has type 1 diabetes?
Yeah, so type 1 diabetics, it's, be important to know kind of what your general control, what your last A1C, and so that would be, true for facial surgery, be true for like really any procedure that you do. So if your, A1C is indicative of like high blood sugar values, then you're at higher risk of having like infection and just kind of like general complications. So you would want, that to be in control with your endocrinologist like prior to undergoing surgery. That having those high blood sugar values prior to surgery can lead to what I said is a risk malunion or non-union, so the bone like not healing well. So that would be a possible outcome if you were like a what's called like uncontrolled diabetic. If you are someone that has, low daily blood sugar values, then it wouldn't be expected that you'd have like a significant, increase in your risk profile. Although it is true that like in general in studies, they find that people that have diabetes are at like, kind of like slightly higher risk just like at baseline, but not enough that like I would never not do surgery.
For sure. Cool. We have 2 questions left. This one is, does a desire for rhinoplasty affect any of the softening procedures that you discussed?
Nope, rhinoplasty can be done in conjunction with anything that we discussed. And again, I've had, when people that I've worked with, like let's say with like non-binary identities, like sometimes they wanted what we would term as like a softening procedure with like having like more angularity like in their nose. So I had one person that wanted to have, like softening of their upper face features and then a more like angular nose. And like, so that's again, it's just making sure that the result is tailored to like what you want to accomplish. But no, certainly nothing about rhinoplasty is one of those things we'll see next time when we talk about it that can be done and is one procedure that can be done a lot of different ways. So you can have a rhinoplasty that like, fits with what you want to accomplish. And for that reason, for me, I just really use like goal photos with people to help demonstrate it so that we're not like saying, like someone's like, oh, I want a feminine nose. And I'm like, okay, cool. Like, what does that mean? And like, I know from our plastic surgery textbooks, but I want someone to kind of like help me see like what they want to achieve. Also an important spot for like race, based characteristics to consider too. So you're not, because all the plastic surgery ideals that I mentioned are all based off of like Northern Europeans, like not
Yeah,
everyone.
absolutely. And for this last one, this person asked, can jaw reduction affect jawbone density later in life?
Yeah, good question. So again, no studies that I have seen that take a look at that or have any like longitudinal data on this. You are reducing the amount of the outer cortex, well, in some versions of jaw surgery. So it would actually take a better knowledge than I have about like how you lose bone in your jaw as you age. So there's certainly like known bone changes in, your body that like result to more like fractures and things like that. But like, I don't know enough about it to know, like, does that also occur in the jaw? It's true you get changes with the way that like your teeth are kind of like fit in your jaw, but is it also true of like the outside of the jaw? So I have to say, I don't know. Makes it a great question. And that someone that you like work with could then, have to do some research, talk with some professionals in that arena to say, because it'd be possible that like if the bone density changes are occurring more in like the middle of the bone, not the outside of the bone, then you wouldn't really have a big impact from facial surgery because facial surgery, impacts the outside. But I just don't know.
For sure. There were a few questions that did just pop up last minute. Curious about time, energy, capacity. Where are you at with that? We have like four. We could,
Yeah,
some
still
of them
good.
are kind of similar, and so we can do a
Yeah.
little lightning round if that feels good to you.
Yeah.
Sweet. Thank you. This person asks, what considerations come into play when it comes to age, not only for face and brow lift, but including age healing? And another person had also asked about for someone in their 50s too. Yeah.
Yeah, so it's always fun when I have people that are in their like 40s or 50s and they know that through like message boards and stuff like that, like a lot of people they're talking with are like in their 20s and they're like, is it okay if I get surgery? And like I'm also like 40, and I'm like, yeah, it's cool. We're good. So no, the age doesn't need to factor in. Again, someone's total picture of their like health is important. So it is true that as you age, more of a chance of having medical conditions that might need to be taken into account, but not necessarily. So I have done facial surgery of people like in their 70s and have not found any significant increase in particular like risks with that. I've done kind of like all the procedures that we've discussed. The older that someone is, regardless of them being like a healthy old person, I am much more likely to do less of these procedures at once. So one thing that we didn't talk about, because we only talked about like one small area, is that with facial surgery, like it could be a whole day of procedures. And I do think that if you're thinking about just age, like a 25-year-old is going to be able to like withstand that like better than like a 75-year-old. And 75-year-olds can, like dox me for that. But it's something that I take into account, that I don't want to like overload someone's, person with this. And like typically they agree with me.
For sure. You were touching on the last question. How many procedures can you realistically do at once? Do you have to focus on one at a time, or can you kind of just go all out?
Yeah, I will tell people, so this is very provider dependent. You'll find people that will, operate like well into the evening. And I'm probably on like farther end of the spectrum that I want to be really mindful for like what we're putting a person through. A lot of people come in that they're like, hey, this is my shot. I need to have all of it done like now. And I don't mind. You read the risks and tell them what it's going to be like to have every part of their face operated on. They're like, okay, cool. I hear you. I got to do it. I limit surgery time on the table to like ultimately 10 to 12 hours. And that's a long time. I try to do it well shorter than that. To think that like you're lying on a bed for 12 hours without moving, you're more likely to get bed sores. You're more likely to have issues with your body temperature, which can cause complications after. You're asking your body to do more in terms of like healing. You're having a 12 hours of anesthesia, which is going to like wildly increase your like, possible like risks from that. You get longer having a breathing tube, that you could get like more like pressure in your, trachea that could cause like nerve damage, or possibly make it that you can't come off the breathing tube at the end of surgery and you'd have to like have a prolonged stay in an ICU to come off the breathing tube. These
Mm.
things are like rare, but they're possible. And so for me, I shorten things and I'll do like 2 days of procedures with like 1 day in the hospital in between. So I'll do like half of the surgery on Monday, then like wait a day and do like the other half on Wednesday to like limit the overall time so that you can get more procedures done in one sitting, but it's not like all in one stretch. So yeah, the ultimate is I joked when you said there's gonna be a lightning round because I don't ever answer any question quickly. But yeah, every provider is different. There's some people that like they love to do these like long surgeries. It's not my personal practice, and I'll help to explain people that I work with like why. And again, like with me, we just come up with like a plan together that like works with their resources and my resources as a human.
For sure. And maybe in like the inverse, is there an impact or a limit that happens if you don't do all of them at the same time?
Nope, I love it because it's important. You could like if you decide to do it in a much more like staged fashion, sometimes people come to me and they're like, well, I really want my brow done, but and I like my nose, but I think when you change my brow, then I'm not gonna like my nose anymore. And that to me is a sign to be like, well, let's just do the brow and then you can see because you don't know. And we could potentially like save you from having to get like a nose job because, we're not sure. We're just like projecting. And so I think if someone is, again, they're like, I'm happy with my whole face, but I just wish that my brows were a little higher. Like, great, like, let's just do that. Like, that'll make it so that it's, much easier for you to like undergo as a person.
Mm-hmm. Cool. And is there like a period of time you'd have to wait in between?
It depends on the procedure. Like if you have one like your nose that you've like broken the bones, you'd like want those to be like well healed before you did another procedure where you were like putting in oxygen masks on someone's face. So
Yeah.
I typically say like the absolute shortest I'd consider is around like 6 weeks. It's typically sooner than someone that's had facial surgery like wants to like go another round anyways. So probably the average is more like 3 months and anything beyond that is like fine too.
Oh, there's just one question on here that asked about like how do you get your insurance to cover FFS? I'm also sending the trans equality page for the Trans Health Project. They have, oh wait, let me send the actual link. They have like an extensive list of resources around getting your trans health and your trans surgeries to be covered by insurance, but curious if there's any caveats that you would want to say about it.
Yeah, I, in a wonderful way, I'm like very uninvolved with people's like insurance journey. And I'm very like privileged to say that I just get to like show up to work and like and do surgery and that all of the work that someone did to like work with their insurance was done prior to them meeting me and we can just be like happy and do surgery. I do a lot of cases on insurance, so it is certainly possible. What I would do is you could explore like your personal benefits with your plan. Each plan has a list of like what it covers and what it doesn't. So you should be able to get an answer of like, is gender affirming facial surgery covered or not by my plan? They medical plans will have this listed like available to find like on the internet in some cases. And but otherwise you could call like the phone number on your insurance card to ask specifically. That's like a theoretical, like, do you just cover it at all? It would then be not necessarily something you would need to do as a person, but when you pick a surgeon that you want to work with, they would have, resources to help get this accomplished, like with you. And so, like, we have our like insurance, like ambassadors and our insurance team that like takes care of it for people in most practices that I'm aware of. Don't leave it up to the individual to get it covered. We take care of it like ourselves. So that would be a way. It's more involved because you'd have to like make, have a consultation like with a surgeon and get as far as like making a plan, but could check your insurance coverage that way too.
Great. Thank you. This last one I wanted to address because it's been at the top of this Q&A box. This person said that people may not pass despite every surgery, and it's something that they said happened to them. And they said people need to understand this to have realistic expectations. I do, I want to say like that is everyone is going to have their own unique experience and their own relationship to what surgery does or does not do for them. I think that not everybody has the goal to pass. And also, I understand why people would feel the need to pass, especially in the current state of like the political climate. There's a lot of optics on just trans people and trans lives and trans existence in general. And it feels really, really scary to be incredibly visible in this type of world. And it makes sense for folks to have a reaction of wanting to be invisible and wanting to be stealth. Like that is super, super real. And also, I just want to say that, you know, like if we're going with the science studies, like less than 1% of trans folks regret their surgery compared to like almost like 20% of people regret going to chemo, you know? And so like that's just like on the data side of things. And I would say that like we know ourselves so well, like we know ourselves so much better than we think we do, and that like anybody else will ever be able to understand us. There's so many systems in place that reject us from even trying to see if something would work for us, and that like we don't get the opportunity to not know sometimes if something is going to work out for us because of that. We have to know so well that we want something so badly just to even enter the door of getting a letter approved or to get your insurance to approve. But trans people deserve to experiment and to be in the gray area and to discover yourself and rediscover yourself over and over and over again. And that like, yeah, I just constantly think about my friend who was getting top surgery and they were 28 years old, and they were like, I asked them about how they felt and they're like, I'm honestly not really sure. I don't know how I feel about getting top surgery. I don't know if I like it or not, but at the end of the day, I've been in my body in this way for the past 28 years. And if I have, and I know how I feel with this body, like it could be kind of interesting and exciting. And I'm really curious about how my relationship to my body will change after the surgery. And I think it really blew my mind that this person was so down to just try and see what happens. And they ended up really liking it. And, you know, I think that like it takes a long time to come to this like self-acceptance of who we are, because we're not afforded that anywhere else except for like ourselves and like our loved ones and our community and like the people who surround us and like uplift each other. You know, that's my soapbox around possibly a very harmless, you know, like comment in the Q&A box, but I also wanted to hold that with a lot of like tenderness and care, and also like provide space for other like feelings around it too. So
Yeah, great.
yeah, I'm not sure if you had anything else you wanted to say about that, but I just needed to put that out there.
Oh, I think that is such an interesting conversation, and I've kind of had it like when I do get a moment to have like a deep talk, more of a deep talk with my patients about it, and is something that's come up. I think you like, you know, you worded everything like so well, but yeah, it's this like bullshit idea that you have to be like, you know, 2000% like sure of everything, you know, that you want, or else you don't, obviously you don't really want it, is what like, you know, these parts of society say. And it's like, you know, I could only speak to my own, you know, experience, that I'm like, well, I'm not really sure what I want, like, you know, for lunch. You know, like there's so many things that I have absolutely no idea about. And like no one's hassling me about like, you know, thinking about that decision. So I would, you know, absolutely say, to the extent that, you know, someone is like able to do so, because it takes a lot of resources to get like, you know, to go and see like a doctor, but to be, you know, encouraged to do what you can to like learn more and talk to people and see how surgery applies like to you. And it's totally fine if you're like thinking about things, you know, and you're still like learning more. Like that's great. And it's fine to talk to someone and not want surgery. It's fine to talk to someone and want surgery, but not feel that they can give you the surgery that you want. That kind of hits on that like expectations, like sort of thing, that is a huge factor with facial surgery.
Mhm.
And so, yeah, it's I hope that you can find, you know, people that you can like talk to in a medical like setting that will be, you know, kind of okay with it. And I'd hope that, you know, going off of that like W path list, like you're going to find people that think, you know, in the way that like that Rai just so eloquently said, and that you'll find, you know, providers that are more likely to be, you know, compassionate than not, because they've taken the steps to get on that, you know, like W path, like referral list, because they want to like, you know, work with the community. So the expectations things come up, like a quick thought about that, because some people like this idea of like unrealistic expectations is kind of like a, I don't know, like black mark on people, or some kind of like statement that's like, well, you have unrealistic expectations. And how I like to view it is just like expectations is like a two-way street. Like you have what you want to accomplish, and a surgeon has what they can do. And just because those don't match up doesn't mean that yours are like unrealistic. And we just said it's hard to get to the doctor. It's hard to empower, like, or be empowered like to get what you want and to like advocate for yourself in that way. But like just because that doesn't like match up, like, or someone's labeled your expectations as like unrealistic, like that doesn't necessarily mean it's true. And I think it's absolutely worth it to have more conversations, that you can, so that you can help figure that out. And that, the more people you talk to, maybe you'll figure out like what aspects, hopefully they'll take the time to like, if they don't think that something is realistic, like educate you as to why, but tell you like maybe what is possible. So, be wary of that, like that label, don't take it personally. Have some people that get super upset and they kind of then go into their next encounter like really looking to like tell somebody like what they need, but try to just say that like just didn't seem like it matched up with that person, and then there's, it's very likely you could talk to somebody else that could help you better.
Mhm. Yeah. Thank you. And I always love the Q&A ending types of situations where we just start getting philosophical for some reason.
Yeah,
I
it's
feel like
good.
that's happened every time we've had a webinar
I love
together.
it.
So
I love to talk about it. I would sit and chat as much as I could. I love your
yeah.
jacket, by the way, I meant to say.
Thank you. Thank you. Thank you. Yeah. I'm like, I have so many thoughts about this topic, passing survival, safety, et cetera, et cetera. But I guess like, I don't know, being like being able to I can't really like find the right words, but I think that there's something about like finding comfort in your body because other people see you in a specific way versus finding comfort in your body when you look at yourself in the mirror and what you feel on the inside spiritually and like emotionally and like how your loved ones and your friends and your community like feel about you. I think that there's something there to reflect on, and there's a balance, but there's something there to reflect on around what what is within your control and how can you feel spiritually like nourished and fulfilled with where you're going with your gender journey and finding your authentic self. That's all I could hope for. So anyway.
That's great. That's a great conclusion to this talk. I love that I was a part of this. Like for that reason, you've said so many things like so like eloquently and like profound. So I'm so appreciative to be a part of this.
Oh, thank you. Super, super appreciate you too. Just wanted to move into our outro as we're getting quite late. Thank you everybody in the chats and also just all of the reactions too. Just loving. Yeah, I love this community so much. Speaking of, I'm always down for feedback. If y'all loved it, if y'all hated it, just let us know. And also what types of events you'd like to see in the future. If you like these rambling philosophical questions, let us know. If you're like, please give us more logistical details about surgeries. That's okay too. Let us know how you feel about that. You'll also get the survey after this event is over to in your email. And again, we're collaborating with the GCs, with the Gender Confirmation Center. So many different surgery events hosted by so many different people. Our next one is going to be around BMI, surgical eligibility, and patient safety with Dr. Jacobs. We're bringing Dr. Facque on for transfacial surgery part 2. We should talk about if we need a part 3.
Yeah.
So we can email about that.
We can check.
Also, if you're able to send me the slide deck too, that'll be amazing.
I will.
And yeah, and all of the different things Dr. Lay is going to come on for all things bottom surgery. So yeah. And with that, thank you so much for being here. Thank you so much for spending an hour and a half of your time with us. And I hope you have a good rest of your evening. Dr. Facque, if you have anything else if you want to say.
No, thanks. Hope everyone has a great night as well. And thanks for all of the nice comments that I saw in the chat. It's really great to be in, such a nice, like supportive place to give a talk.
Yeah, absolutely. All right. Have a good night, everybody. Take care. Bye.